Hello, and welcome to the show Beyond the Journal, where we will discuss social media, digital education, and current controversies in cancer and medicine. I'm Dr. Jack West, Associate Clinical Professor in Medical Oncology at the City of Hope Cancer Center in the Los Angeles area, and I'm happy to be joined today by my co-host, Dr. Charles Agarwal, who's the Leslie M. Heisler Associate Professor of Lung Cancer Excellence at the University of Pennsylvania's Abramson Cancer Center in Philadelphia. Hey, Charles.
Hi, Jack. Today we're pleased to have on the show with us Dr. Dizon, who's the Professor of Medicine at Brown University. Don, thank you so much for joining us.
I'm really thrilled to be here. Thank you so much for the invitation to both of you.
So, Don, we wanted to ask you a few questions that span a few very interesting topics, but, really wanted to start off with your connection with people and your engagement on social media. You've been one of the early adopters of social media and one of the first oncologists to embrace TikTok. And your style has really evolved over time, a little bit of fashion, a little bit of pizzazz, and now patient education. Can you take it back? Can you take us back to how it started?
Sure. It seems like I've been on social media for a long time, but really I can trace back my engagement on Twitter, which was the first social media platform I used professionally. It was when ASCO asked me to head this committee, which is no longer in existence, called Integrated Media and Technology. And I didn't know what that meant, but I had heard it's about new ways to communicate, social media. So that's when I joined Twitter. And actually, through IMTC and on Twitter, I was started to engage with folks who preceded me, like Michael Fish from MD Anderson, Robert Miller at the time from Hopkins, and they sort of provided sort of the open door to what Twitter was. And I started following them and started learning about hashtags, and then all these people sort of started tumbling into my feed, like MJ Markham, Dr. Jack West, and then more recently, Dr. Agarwal. So it's been almost a granular experience, but the social media lesson I took away very early was the challenge to communicate in short snippets. And I thought it was brilliant, because we're at a time where I grew up in oncology where people just waxed poetic for days. They're talking about their cancer and talking to patients, never gave a patient a chance to ask a question. They just talked. And here was this new medium where you only had a little bit of time to talk. You only had to measure what you were going to say in characters. And I thought it was genius. And it was a challenge to me to how to utilize that to say what I wanted to say in a very short amount of time. And that's sort of how I sort of use Instagram now. And then when I went to TikTok, the beauty of the TikTok platform for me was the visual aspects of it, because I'd learned, I think, even from lessons that you both have done on Twitter, that anything visual, whether that it's a PowerPoint picture of your takeaways from a national meeting or a presentation, that picture, it leads to more engagement than just words on a screen. So TikTok for me was the natural evolution of the visual element. So even though I film things on TikTok, I transport it to other media. So I'm the same social media persona across platforms rather than having one persona per platform, which I think is crazy and probably lends itself to mental disease.
So, but it's interesting. I think one of the things that people like and don't like about Twitter is that, you don't have to approve people usually as to follow you, and your audience is diverse. I mean, we expect that we feel like we're speaking to our colleagues in medicine. Mm-hmm. We're also talking to patients and caregivers and pharma and the finance people. They're all following our conversations, sometimes engaging. When you talk about the platforms, they do have different strengths, and certainly to the pathology and radiology people, I think there's a special resonance with Instagram, for instance. That you can share images that are your stock and trade in pathology and radiology more than to us, although we're all visual learners, I think. But do you use the platforms to reach different audiences, or how do you think of how you're going to use TikTok versus Twitter versus, or do you just, I know that some things you put something from TikTok on Twitter. Are you using the same content, or do you customize in some way to reach a different audience? Who do you envision being your audience?
I think that's a really interesting question. And I'm going to tell you my take on all of it is I want all of us to use the same language. So I'm all about communicating in ways that is accessible to everyone, whether you're my colleague in oncology or, you're just learning about cancer for the first time because it's affected your family, or it's just, Joe Schmo from the general public who just stumbled across it. I think that whatever we're putting out there, we have to assume it can be seen by anybody. And if that's true, it has to be understood by as many people as possible. So I try very hard to, and it's sort of, it's a challenge I like to take on, actually. How can I say something that's not going to be accessible to everyone, that is going to be accessible to everyone and not restricted to just my peer group? It's a great take on that is right now, San Antonio Breast Cancer Symposium is going on, and there's a lot of chatter among oncologists about the findings in there. So I actually am trying not to use lingo and just saying, this is an interesting finding. So what do you plan to do about this, Dr. So-and-so? And then seeing advocates sort of chime in. It's a really rich experience, and it lends itself to a lens that we didn't really have before.
Well, it's interesting also that open notes has evolved as a concept, as a practice in the last few years. And I think of it in the same way that I don't mind that people should be able to see my notes, because I am not keeping anything from them. Anything that they would read in my notes is something I would say to them directly. And so I think that we should be ideally comfortable with that transparency, that authenticity. I mean, I think you don't get into trouble if you're not a different person in different groups.
I think the whole issue with communication, and I think Open Notes is a great example of this, there are shortcuts we take in our professional lives, and it makes our job easier to get through. Because, medicine is a hugely human endeavor, but there's a huge technical and administrative component that none of us really enjoy. So we have these shortcuts that makes that administrative component bearable. It might be copying things forward. It might be using the lingo. I might tell you as a patient, things aren't going well, but I'm hopeful. Well, we'll put our note, prognosis is poor, third line treatment after failure on therapy is such and so. Essentially, we said the same thing, but the lingo doesn't translate to the communication. And I think that's where the concerns are. It's sort of, you're opening Pandora's box, for example, and saying, now you're going to ask me to then translate this administrative component of my job for you when I told you the same thing, but in the parts of my job which made me become a doctor in the first place. So I think that's really what it comes down to. But I think this is where social media can help all of us, because if you don't have this sort of dichotomy of how you're talking to your colleagues and you're talking to patients, it helps you to sensitize to the fact that everyone can read whatever you wrote. and everyone can see whatever you did. And that is translating to our lives as professionals. Yeah, completely.
Yeah.
Yeah, I think you make a great point about also being brief, because with, I think, brevity also comes clarity. So I think that's a great point. I want to take your engagement in social media a little bit further and ask about how you've utilized this in clinical trials. You've been a champion within SWOG, within the Digital Engagement Committee. What do you foresee as some of the benefits of social media engagement, and where do you think we're headed?
Yeah, that's a really great question. I think it has been unrealized. Let me put it that way. There are efforts to use Facebook to help with recruitment outside of oncology. More it's in the social medicine, social sciences strata, where they're looking at depression in adolescents using social media tools to engage in these campaigns to increase rates of uptake of protective medications, for example. But in oncology, where the group we are trying to help it's fairly restricted in terms of population level stuff, but it's also the stakes are so much higher and the trials are so much more complicated. So I don't think we've been able. We're still thinking through how we could use social media. But one of the things we're trying to do to help all of the folks who are doing trials through the National Clinical Trials Network, especially through SWOG, is equipping new trials with social media toolkits that can be accompanied with that protocol towards an IRB review, whether that be central or at the institution, just saying, here's a series of tweets, here's a series of infographics, here's a series of Instagram posts that you can use to highlight your trial and hopefully drive engagement. And then the question is, does this passive amount of work translate to faster recruitment on the trials themselves? I mean, I think that's one aspect. And then the second is, after COVID-19, where everything has changed, what can we do to help revolutionize old practices in clinical trials? So, what can we do with telehealth as far as informed consent comes in? Do people need to literally sit for an hour with either me or my clinical research nurse and go through every bit of that protocol? Or is there a way to utilize social media to say, these are the common elements of all informed consent, and we're going to package that into a video so that time specific to that trial is now shrunk from an hour to maybe 15 minutes. So there's a lot of conversation about the lessons COVID-19 has taught us, and especially those lessons that we should carry forward rather than say it was a temporary thing. And I think there are really interesting conversations going on right now.
We were all using social media professionally, personally as well, before the pandemic. But now the pandemic has changed the world. And one big way is medical meetings and how we have the opportunity to interact. You brought up San Antonio Breast Cancer Symposium. Is social media now even more indispensable as maybe the primary or only modality to interact and go over data together, because we can't do it in the same conference center, to the point that people who are hesitant are really missing out now on a key component of academic, of collegiality?
I think they are. I do think it has become so much more important, because the nice thing about meetings is the ability to engage with your colleagues one-on-one and face-to-face and say, what did you think of this data? What are you taking away from it? And this is what we did at these meetings. And those are the opportunities that we've lost. But social media can allow those interactions now. And what I think I'm seeing is, for those of us who are engaged in those conversations, even if we're just monitoring them, like I monitor the conversations around phase 3 lung cancer trials that just sparked so much controversy on social media, and I was learning something about it. I'm not going to mention the trial.
I don't know what you're talking about.
But what I found is when I go into clinic, right, with my colleagues who are not on social media, they are so surprised that I heard about it and that there was this engaged thing. And then, oh, well, did you think of it this way? And it's just a surprise to them that I can come in with so much more nuances on the conversation when there was no opportunity to do that during the sort of virtual realm. I mean, we try to do it through ASCO, right? They had this sort of, text chat that was going on, which I found, not very helpful, but you go on Twitter and the feedback is just live and it's coming from everyone. So not just oncologists, but like we were talking about, Jack, it was, patients and advocates and industry reps, and they were all involved in a conversation. And I thought it was fascinating. I learned something every time.
That's great. I think that's a really interesting point, that it helps break down some of our silos, because I would literally not be in the same part of the convention center where the key meeting, presentations are happening outside of lung, and we tend to only travel in packs with our immediate colleagues. I think it's certainly commendable that we're diversifying who we follow on Twitter for all sorts of reasons, and that enables us to keep up a little bit with the crosstalk and cross-pollination too, because how different people think about neoadjuvant therapy and the right endpoints, et cetera, should help inform us, and we should have some idea about how patients may respond again to different immunotherapy approaches after progressing on prior immunotherapy in renal cell or melanoma. I mean, there is a value in not becoming so hyper focused that we only see lung cancer work.
Yeah, it's sort of like, the way I almost see it is, where oncology is so far removed from general practice, right? It's almost impossible to be a general oncologist, although, there are people who do this exceptionally well, right? Social media allows you to still keep an eye on what's going on outside of your areas of interest, but in a way that's almost a little bit more informed than reading a trade journal, because you are getting this nuanced look at things.
Yeah.
I agree. And I think something you said about engagement around clinical trials, have you noticed through your work within SWOG as well as NCTN that a particular platform is more perhaps better geared to interact with patients and advocates and caregivers? Or do you think it doesn't matter as long as the message gets out there?
No, I think it matters greatly, actually. So I think that's a great point. If you look at who's actually on Twitter, it's a very selected group. All of the demographics that I've ever seen in a social media study using Twitter: white, educated, upper to middle class. It's not to say that low income or vast diverse communities aren't on Twitter, but at least the folks responding to surveys around social media when we use Twitter, it's a very restricted data set. So I think you still need to go out and ask, where is your community meeting? Where is it? It might be WhatsApp, which no one's ever used, especially not in oncology, but it might be Facebook. It might be these interest groups, it might be in patient communities, which are restricted and don't allow physicians in, because they want it to be a patient community. So I think, asking the question, especially with clinical trials, how do we use Twitter to get our message across? It's a too simple question to ask. It's almost, who do you want to reach, and how can I reach that group, is really the smarter question.
Have you cracked that within SWOG yet for some of your trials? It's such a hard question, as you point out.
Yeah, it is a hard question. I think for even right now, there is much more engagement of patient advocates, a lot of whom have access points which we don't have. Either they're moderators in closed groups on Facebook or these other communities, or else they have their own social media persona and they can amplify their voices. So these advocates are really not only involved in the creation of trials from the start, but we are relying on them to help push out the word, especially when a new trial is open. I can tell you that depending on the focus of a trial, if it's a supportive care trial, for example, versus a therapeutic trial versus a tissue collection trial, the enthusiasm of folks to sort of engage around them can differ greatly. Yeah.
But I also think that patients have their own credibility and expertise. Obviously, when we talk about experts, we're thinking about professional, knowledge-based expertise and subspecialization, but there's a special credibility that comes from living it and having taken the therapy. And I would say that it really resonates with other patients and caregivers. And I think it's a great partnership if SWOG or if any clinical trials group can work in partnership with a patient organization as a kind of symbiotic connection. I think that can really accelerate research if we just figure out how to crack that nut.
Right. And it's proven you can do that, the Count Me In, which is like, this metastatic breast cancer trial. It's not therapeutic, but it's trying to collect genomic as well as clinical data. Very effective because they went on social media. They had a hashtag, they had a campaign, and it took off because it made sense. There was, the buy-in was obvious. We want to learn the biology of metastatic breast cancer so it can lead to more breakthroughs. Really easy. Count me in, hashtag count me in, But that's hard. It's sort of like the idea of how does one go viral, especially around clinical trials. That's not an easy thing because it doesn't lend. It's like saying, how can you cure cancer? It's like, well, what kind of cancer are you talking about? Breast cancer. Well, what kind of breast cancer are you talking about? Well, what kind of triple negative? Our field is getting very complicated. And I credit the lung cancer community greatly for showing what can be done, with activated, engaged patients. You can see what can be done. You can you can find each other. You can back a study, that's incredible.
Well, I think that the challenge is when you're talking about 1 to 5% populations, that means it's really hard to be in the same place at the same time unless you have an EGFR summit or something.
Yeah.
That the geographic dispersal is a challenge that can really be overcome by meeting online. That makes sense. And I've long felt that the narrower the population, the stronger the self-aggregating affinity online. That there isn't an incredible gravitational pull for squamous, which is not as exclusive as ROS1, but the ROS1ders are an incredibly tight forward group that that makes sense because it's a tight community that cannot be emulated offline easily because they're just geographically dispersed.
And I think outside of this field, if you look at say what the Ovarian Cancer Research Foundation has tried to do with they've tried to do a woman-to-woman program, sort of fund centers. We have one of those grants where we can train our own community to help other newly diagnosed women with cancer, find someone to help them walk through the process. But that's in the era of support. The goal there is not to say, oh, and we need to inform them of the recent advances and the high profile. That's not part of that, whereas ROS1ders are sworn because, what they do is point towards active treatments, active trials, active options, and priorities of this community, So, there's something to be said about, and it's a term I use, although I'm not terribly comfortable with it. It's like, when you're activated, there's different levels of getting activated as a patient. One is just at the very least, You should be your own biggest advocate. But then one can grow, and that's what we've seen. People can grow and say, I'm going to advocate for this tumor type. Why don't we know more about this? And I think that's the bigger question that prompts us to do more work.
Well, it's really great to hear that, you're actively engaging and thinking about dissemination as it relates to clinical trials. I want to change topic slightly and talk about, sort of equity and the question of, your title changed recently from Director of Women's Cancers to perhaps being a little more inclusive, of course, thinking about trans men getting ovarian cancer. Can you talk us about what went behind this change?
Sure. It's been an interesting thing. When I was at the Mass General before I came to Brown, I was the clinical director of the gynecologic oncology program. It was very, very specified. So, for the most part, in my 5-6 years at MGH, I never saw a man with ovarian cancer. And quite frankly, gynecologic oncology is its own subspecialty. But when I started doing breast again, coming into the Providence, Rhode Island and Lifespan's Cancer Institute, 3 people came through and they were men with breast cancer. But my business card said Director of Women's Cancers, and then all of a sudden became very obvious that, when you're being followed for breast disease, not breast cancer, you go to a breast health center, That's where you go, not a women's health center. It's the breast health center. That's where you get your mammograms, your MRIs. You see a breast surgeon, But here are these men coming through for medical treatment. And my card was saying women's cancers. And then you couple that with an experiences that I had in my prior life where I did take care of several transgender men with ovarian cancer and made the mistake of greeting their female partner, assuming that she was the one with the cancer, because she was the one that looked like a woman, and realizing that, you don't need to be a woman to get ovarian cancer. You have to have been born with ovaries, And then this all came to, when I, did a TikTok about this experience. And the whole point of this TikTok story that I did over 60 seconds was to bring the point forward. You don't have to be a woman to get ovarian cancer. You have to have been born with ovaries. And someone pointed out a comment on Instagram. So I took that TikTok and I put it on Instagram, and someone commented, "This has been sent to me several times. And as a transgender man with ovarian cancer, I am noting that your title is Director of Women's Cancers. That by itself is not helping," and it was true. So that sort of led to this sort of look at what my title was and wanting to be inclusive that way. And so the medical program is breast and pelvic malignancies. There is still a gynecologic oncology program, but the nice differentiation for us here is that gynecologic oncology program is a surgical specialty, whereas we are now the medical specialty in pelvic malignancies. And for breast, it just is more inclusive of the fact that 1% of all breast cancers, probably even less, 0.5 to 1% of all breast cancers in the US happen in men. But it doesn't mean it's not important. And I don't think it takes away at all from the fact that breast cancer is the most common cancer in women, and that, 99.9% of all gynecologic cancers are occurring in women. It's not taking anything away from that. At least I hope it isn't.
So you would say that the reception has been positive overall, or have people not really noticed it as much?
So it was interesting. It has internally, my colleagues have been 100% supportive on social media to this point of, where are your barriers, for example? I did get blowback. Some people were like, "Oh, this sounds very PC to me," or "I would understand what you do. If I saw you online and you do pelvic, I don't even understand what that is." One was even, "This is a very sexist look at cancer. You're ignoring the fact that over 90% of women have these cancers. It should be called a women's cancers program." So there has been, but Jack, I think you mentioned it earlier, sort of when you post, you have to post deliberately, it doesn't lend itself to these sort of knee-jerk posts. And I when I have to talk in this, I always say it's like, don't post when you're angry, you're drunk, or you're exhausted, because you just get into trouble that way, But I do think about what I'm posting now, and then I'm prepared to defend it. And I think that's really important. And sometimes you don't have to, but sometimes you do. And that's okay.
It's interesting because I think that a lot of people's either aversion to being part of social media, or at least speaking outside of a narrow lane of, well, I'll just post Kaplan-Meier curves. I'm not even going to comment on what they mean. There's people, who speak freely and offer commentary, sometimes beyond, I offer as much commentary or more than people want. And there are other people who talk about politics, getting into COVID and masks. And that has unfortunately been a blending of science and medicine and policy and politics. And some of the concern is around criticism and trolls and blowback. And so do you have a philosophy for yourself, or do you think that the physician community as a whole is too cautious and conservative about speaking to political issues? Or do you really have a view that just you be you and nobody should tell anybody else how to do it?
So my philosophy is that, and I don't like the term, but for all intents and purposes, I think it works. Each of us has a brand. Okay. And our brand is our professional. It's our professional persona. It's who we are as physicians. And that does, I think, Jack, you've posted this a couple of times in the past on Twitter. We reflect our institutions, even if it's not something we intend to do, but we reflect who we are and where we work. And, you talk about the cancel culture. What do you think when people are getting into trouble? They are trying to cancel them professionally, and there's been success with that. So you need to do what you can to protect that brand. One of the things I think would be the mistake is to post assuming everyone agrees with you, And I actually say this, within my institution and places where I'm engaged with on sort of a national level, to assume that everyone backs trans rights would be a mistake in this society. To assume that everybody wanted Biden to win president would be a mistake in this society. And to assume that masks is not political is also a mistake. So if you're going to wade into those waters, be very clear about what you're doing, because it's going to be inherently political, but be prepared to back that up. It has to be around mutual respect. So what you won't see me do, because I came out as a Biden supporter very early, on this whole trail, and was asked on TikTok, why do you support Biden? I don't understand why a doctor would support Biden. I didn't go into the litany of reasons, which would have bordered on both political, professional, and personal. But I just picked up a quote and I put this quote out there, and I let people think about what the quote meant. And I thought that was a really, it was a safe way to answer that question, but I think, again, it has to be purposeful. The role of the physician in this society is as an advocate. That's what I believe. We advocate all the time in our daily lives. We advocate for, whether it's, growth factors for our patients on chemotherapy or access to immunotherapy based on the latest phase 3 trial, even if it's not FDA approved for that indication yet. We fight all the time for our patients. So I do believe physicians are natural advocates. What you choose to advocate for is totally within your brand. All right. Yeah.
So I guess one of the questions that you led into this is, you during the pandemic, you were also a very early adopter of promoting mask wearing.
Yeah.
And, of course, you did it with a lot of pizzazz with your fashion.
I make my own masks.
I know, with your fashionable masks. Those were amazing. Can you start shipping them out? Can Jack and I get one of Beyond the Journal?
Maybe.
Did you face backlash personal comments or threats?
Yeah, that's, that what was interesting about that is, and I think you asked me about this before, sort of, my quote evolution from sort of dance to fashion to messaging and stories and all that stuff. I try to disarm whoever's looking at that by seeing not only the message, but seeing a visual, because I think that's really key here. So, I have had a ton of comments. Most recently, it's like all the videos I'm putting on a scarf or a tie or something, neckwear, and I'm tagging a message along with me tying a tie or something, putting around my neck. And I get as many comments about the scarf as I do about the mask. But no, I haven't experienced blowback about messaging around masks, because as clinicians, we are on that front line and we do have some legitimacy about what we're saying. And I'm not out there saying, if you're wearing a mask, you're murdering people. And I'm not saying, if you don't wear a mask, you're obviously a Republican. These are not things that help the dialogue, but if I can get people to think about what I'm saying in a way that is not telling them that they're wrong, then I think that's a good thing, in terms of messaging.
Right. This is something that Vinay Prasad also has commented on. We should really try hard not to politicize medical discussions. We should try to, they're going to be connected in ways we'd prefer not to. We shouldn't accelerate that mixing process if we can avoid it.
Yeah, I mean, we have very good standing in society. It doesn't feel that way sometimes when, physicians are being called out, public health experts are being called out as, quote, liars in our society. But really, I think the vast swaths of society see physicians and clinicians as legitimate arbiters of truth. And I think that does work in our favor. We start to sort of go away from that when we ourselves engage in the political gamesmanship of it all. And I think the voices of physicians, around, vaccines, I've done that before, because around the HPV vaccine, I'm a very big proponent of the HPV vaccine. It's part of my advocacy work trying to get rid of cervical cancer in the world, But these are things where I do think you need to stand on data rather than standing on why everyone else is wrong. Yeah.
Well, this has been a terrific conversation with you, Don. We are so glad that you joined us today. We'll close our podcast, but I'm sure we could have gone on speaking for another hour or two easily. You can find us on iTunes or wherever you find your podcast content. We hope that you will subscribe and send us comments and feedback to beyondthejournalshow@gmail.com. We would like to thank Mark Lindsay and Talking Speaker for production and distribution support. See you in a couple of weeks with our next podcast.
Thanks so much.
Thank you so much. You guys do such a great job. Happy holidays.
Happy holidays.